I'd like to state that the information shared on this webinar on Tuesday, May 17th, 2022 is current and up to date, but may be subject to change. And we ask that you defer to the MSC payment schedule or the GPSC preamble or GPSC billing guides or the most appropriate the appropriate guide to determine what the most accurate information is. Okay, checking the chat, seeing nothing there, we'll get started. Cathy, Tracy, the floor is yours.
Hi, I'm Tracy Monk, and I'm a family doctor in the Fraser Northwest Division and the physician lead for provincial pathways, and I sit at the GPSC. And Cathy, would you like to introduce yourself as well?
Sure. I'm Cathy Clelland. I too am a family physician in the Fraser Northwest Division. I have a number of hats that I wear, but one of those is I provide maternity care at the Port Moody Maternity Clinic, formerly known as the Community Maternity Center. So we've changed our name, but anyways, I shall hand back over to Tracy for the first set of slides.
All right, so overview of what we're going to be presenting today. To start with, we're going to review the billing eligibility for maternity related fees. And then later on, we'll move to the new fee, the maternity care risk assessment and the early pregnancy care algorithm that's in Pathways. Then we'll review some of the basic prenatal MSP fees, and then we'll just quickly review the clfp new patient intake that you can use when you take a new baby and mom into the practice. So who can bill GPSC maternity related fees? Community longitudinal family physicians or maternity care providers registered in a maternity network or locums covering for either of the above. What are the GPSC maternity related fees and incentives? That's the 14002, the new maternity care risk assessment that we're going to discuss today. And there's also the 14010, which is the maternity network fee for physicians who are doing deliveries, and the 14004, 5, 8, and 9, which are the low volume delivery incentives for physicians who are doing deliveries. And later in the session, we'll cover the basic MSP maternity related fees. So community longitudinal family practice, why do we, what's the evidence to support the importance of valuing community longitudinal family practice? There's overwhelming evidence from something like 137 studies summarized here about the fact that patients who have an enduring relationship with the most responsible provider have better health outcomes and lower costs to the system. And I love the way this particular slide, this particular summary from actually the folks in Alberta who produce a lot of excellent evidence summaries, explains the evidence. So what's the definition of a clfp? It's a person who is doing all of the following. They're assuming the role of the most responsible provider for a known panel of patients, confirming their doctor-patient relationships with a compact. They're providing coordinated ongoing care. They're working in community settings, such as offices. They might provide some virtual services, but purely virtual care is not community longitudinal family practice, and a community longitudinal family physician maintains the comprehensive records of each patient. Person is not being a community longitudinal family physician according to the definition if they're doing purely episodic care, purely virtual care, purely focused practice, or working purely in a facility setting. That when you're a clfp provider, you submit the 14070 portal at the beginning of each year, or if you're about to graduate in the summer, you'll submit it as soon as you graduate if you're going to be joining a longitudinal practice. Otherwise, you'll submit 14071 if you're going to be working as a locum. But if you're going to be joining a practice in the summer, then you'll submit the 14070, and 14070 submission opens the portal to all of these additional fees, including two that we'll be talking about today, the new maternity care risk assessment. And back in the fall of 2021, there was the new CLFP new patient intake. But all of these fees worth thousands of dollars are behind the CLFP portal. Now over to you, Kath.
Perfect. If you can stop sharing your screen and I can share my screen.
Perfect.
Won't let me with you doing it. Thank you. And I'm going to do it from there. Excellent. All righty. So thank you for joining us, everyone. I wanted to touch briefly, first of all, on what are the codes that are available through the Maternity Network. So being a part of a maternity network is being registered for the maternity record network. It's not about which codes you're submitting. So unlike the CLFP 14070, to be registered in a maternity network, there's a registration form that needs to be completed and submitted. Once you're registered in a maternity network, then the new maternity care risk assessment fee, 14002, is billable. Several of the other GPSC conferencing codes are also available to family docs who are members of maternity networks, along with the delivery codes and the actual maternity network fee, which is for being in a network of family docs who provide delivery care.
I just want to clarify for people who don't do deliveries that they don't have to do that to be able to bill the 14002. To bill 14002, you can be a CLFP. And if you don't do deliveries, you don't need to worry about the maternity network incentives.
So the network incentives are for those who are either as part of their CLFP or separately in a focused practice providing maternity care. So we're now going to talk a little bit about the actual new fee, the maternity care risk assessment fee, and then I'll hand back over to Tracy to go through the wonderful early pregnancy care algorithm that's been developed for Pathways. It's quite a remarkable tool, and I think you'll find that on the demonstration. So first of all, who can bill the new 14002 maternity care risk assessment? So it came into being effective April 1st of 2022. So it is only billable for services that are provided from April 1st onward, not for anything prior to April 1st. The value is $50 and it is billable in addition to a visit, provided the visit is separate from the risk assessment. And I'll get into that a little bit more particularly as we go through. It is billable by any CLFP, anyone who has submitted 14070, or for those who are locums working in longitudinal practices. If 14071 has been submitted, you can also access this code. It is, of course, also provided access through the Maternity Network. And as I said, the locums covering for either of those sets of docs. So first of all, the details, the 14002 is billable in general once per pregnancy per patient, except in the case where a patient transfers their total ongoing prenatal care to another physician. So for those of you who are in longitudinal practice who may follow the care of your patients up to the end of the first trimester, mid or end of the second trimester, but you don't do deliveries, you don't do intrapartum obstetrics, you get to access this and bill it for doing that service earlier in the pregnancy. And then the physician, the family doctor that you have transferred the patient's care to, who will be part of the group, the team that'll be doing the delivery, they also can bill the 14002 the second time, because they will have had to review everything that happened up to that point and discuss any risks that may, the risk assessment for activities that may be coming beyond that visit. It is, as I said earlier, payable in addition to a visit fee, home or office. Most of us provide our care in offices on the same day if medically required, providing the visit does not take place during a time interval that overlaps with the face-to-face planning. So what the example that we give is if you've seen the patient who they've had a home pregnancy test that's positive or something like that, and you've had to also deal with nausea or other things that are not about the risk assessment, you get to bill a visit for that service. So during the pandemic, just like the other GPSC planning codes, the 14066, the 14002 can be billed when you are providing the service virtually. We will see as the pandemic continues to settle down where that goes, but as of today, it is billable when the service is provided virtually. The 14002 is not billable on the same day as the 1400066. So the personal health risk assessment has, or the maternity care risk assessment actually contains all of the elements that are in the 14066 as well. Please don't. And as a result, you cannot bill them on the same patient on the same day.
There's a couple of questions, Kath, that maybe we'll tackle.
Yeah, I don't have my Q&A open, so if you can.
So somebody's asked what ICD-9 code, and I don't think there's any specific ICD-9 code.
So yes, so the ICD-9 code, you can use 30B, which is what most of us use when we're doing any prenatal care. If the person has a specific risk factor, for instance, maybe if you're taking care of them a little later in the pregnancy, when they're transferred to you and they have a history or a risk of hypertension in pregnancy, then you can use the relevant code for that specific risk. But otherwise, it is fine to bill it with just 30B, the same diagnostic code as we use for our prenatal visits.
There's no specific limitation in MSP.
No.
So whatever you're used to using is okay. And then the next question was, can it be billed in addition to a prenatal visit? Yes.
Yes, and we'll get more into the details as we go further along as well. So absolutely, there's no restriction as to which types of visits it can be billed in addition to. Just the main thing is that it has to be a separate, contiguous service as opposed to part of the same piece. We'll get into that a little bit more as we go through. So what is expected as part of the risk assessment? So it is obviously reviewing the history, including but not limited to all of the things that are listed there. For any of you who've looked at the antenatal record, that prenatal form that we fill out, that a copy goes to the hospital to be included on the patient's chart there, everything that's on this list is basically what's on the first page of that antenatal record. There is this section at the bottom that is around the physical examination, which is separate from the risk assessment, but all of these components are the same as what's on the top of that first page. So the documentation options, provided you have a chart note that outlines all of those elements, that is adequate if that's what you wish to use. However, if you do happen to use the antenatal record part 1, the first page, as I said, this is a screenshot of what it looks like. Most of it, there's a little bit more below it, but everything that's in that list is on that first page. The complete physical documentation is the bottom third or so of that sheet, and that also will appropriately be accepted as the documentation. If you are documenting in an antenatal form like this, all you would need to do in your actual chart record is to document, see antenatal record for details of antenatal prenatal risk assessment or maternity risk assessment. That would just, it references where the documentation is being held. If you are providing an additional service, not just the risk assessment, as I said earlier, the example, someone's got nausea, so you're giving them some advice about fluid intake, whether or not they may want to try medication, other dietary advice. That's the medical visit that is separate from the risk assessment, and for that you would then bill the office visit. Again, in your chart, you would need to document that the maternity care risk assessment service was provided separate from the medically necessary visit. And that's just so that if there was ever any audit that went on, it was documented in the chart. There is no need to document times to submit to MSP to show that they're separate times, but you do need to document in the chart that they are separate, two separate services that are being provided.
So there's a few more questions, Kath. Can I bill, and we really just answered this, can I bill 14002 with 14090 on the same day? And
Yes.
yes,
So whether it can be a prenatal visit, the 14091, if you're not doing the full physical, if you're doing the first prenatal full physical, it can be billed at the same time as the 14090. If you're not doing it with either of those, if you're say you're only at 7 or 8 weeks, and you can bill it with the office visit. So any of those codes can definitely be billed in addition to the 14002.
just make your chart note. I just make separate headers like I do when I'm doing the 14066. This part of the visit was about a concern, and this part was the prevention, or this part is the prenatal risk assessment.
And some
We
of the
also have,
EMRs are set up so that there's an easy way to do that. Others will use it, just they'll template it within their EMR. So it's whatever works for you.
another question. When we receive a transfer of care for ongoing care in pregnancy, we have billed 14090. Is this instead of the 14090 for transfer from another family doctor?
No, it is not instead of, it is in addition. So for if you're accepting care, so I work at, as I said, the Port Moody Clinic. And so we often, a lot of the patients we see, we're not seeing them till 16 to 20 weeks. They'll have had some initial prenatal care with their family doctor, who may have done the maternity care risk assessment there, as well as their initial complete physical. When we then see them as a transfer complete physical, obviously if their family doc has already done the PAP, you're not redoing it, may not be necessary, but you're doing your intake CPX. You can bill both the CPX, the 14090, in addition to the 14002 for the review of the maternity care risk assessment components that have been done by the family doctor, and any additional follow-up or next steps that are appropriate based on the gestational age of the patient that you've accepted in transfer. For both the CPX, the 14090, and for the 14002, when you go to bill, to facilitate billing appropriately, because both of those can be billed a second time in the patient when the care has been completely transferred. In the electronic note of both 14090 and 14002, you should put a note that states transfer of care at X weeks, whatever stage they are at that point, transfer CPX and maternity care risk assessment, so that it's a part of the note record, or part of the electronic note record that goes to MSP, and that will allow the computer to process those codes and not reject yours if the family doctor who referred the patient to you has also billed them earlier in the pregnancy.
Somebody has put in the chat, and I'm going to speak the question, but please in future put the questions in the Q&A, not in the chat. But somebody's asked, can two people in the same office bill a 14002 on the same patient at different times in the pregnancy, for example, on call? And no, the 14002 is billable basically only once per pregnancy, but if the care is transferred to another physician, in a maternity network, then with a note record, it can be billed the second time.
So the only caveat there is MSP still, so neither the 14090 nor the 14002 would be billable if you are physically in the same office. That's an unfortunate stumbling block that we have run across and are trying to address, and will continue to try to address. But if you are partners in one office, you cannot bill, only one person within that office can bill it, because you're not considered to be a transfer of care to a completely different practice. So that's unfortunately the one exception. You will have the same data center when it gets submitted usually, and that unfortunately will end up causing a rejection.
But conceptually, think of it as it's billable once by the MRP, and if the MRP does not do deliveries, upon transfer of care to somebody who's going to be doing the delivery, that person can bill it. But it's essentially billable once per patient per pregnancy, and a second time if the care is transferred to somebody who does delivery. That okay? And then there's another question. So the bill, for instance, 13437 plus 14002 code 30B. And this would not require additional documentation for additional visit, i.e. nausea and vomiting of pregnancy. No, you do have to have additional documentation for your visit. And then there should be documentation. So you should document your visit and then document the part that is specific to the maternity care risk assessment. So go through the specific factors of talking to them about genetic screening and assessing their risk factors and smoking and alcohol use and stuff. So there should be two headers if you're going to in your note, if you're going to be billing
And
two
an
codes.
additional note that states the two services are done, like one was done before the other. For the most part, most of us will do the risk assessment first, followed by whatever the physical visit component is.
There's a question, is there a yearly max?
There is no yearly max on these. It is what per patient max, not per provider max. I'm wondering if we should hold the questions until we get to the question period so we can get through all of the slides, please.
Okay.
Anyways, I will stop sharing because I'm playing tag now again with Tracy to now help you to show you some of the cool pathways that she's got.
All right. Here we go. So on to pathways here. So we're going to be talking primarily about the clinician login portion of pathways. And if we could launch the poll, Katrina, I just want to get a sense of how many of you use pathways now, whether you use it daily, weekly, monthly, unsure, or never. Is the poll launched? I can't actually see it. Okay. Oh, there it is. All right. How often do you use pathways? Okay, so there's a few people who don't use it or are unsure about it. So we should make sure that you get a login. And if you can go now to pathwaysbc.ca and hit request access and just get yourself set up so that you have an account in Pathways from now on, because I think you're going to find it useful. And the other piece of pathways that we're not going to get into too much today is this part here, the medical care directory. But if you click that button, you'll see that you get to pathwaysmedicalcare.ca, which is a directory of family doctors, a directory to help patients who don't have a doctor or who need care that day to find care. And there's also a new section, just had a soft launch last week, the Find a Maternity Care Provider that's been developed collaboratively with the GPSC Maternity Working Group. And so it would be useful if all of you can take a peek at the Find a Maternity Care Provider and then search by city in your geographic area and see if it looks to you like everything, all the providers that should be there are there, and to let us know at Pathways if anything looks incorrect. So maybe all of you could just go quickly to pathwaysmedicalcare.ca right now and search your city or town, and I'll just show you how to do that. So if you go to the medical care directory and you're going to search your city or town, and I'm going to put in, say, Coquitlam, and see, we get a list of 1, 2, 3, 4, 5, 6, 7, 8, 9 different options. See the different pins on the map. So I'd like each of you to do that for your area and then enter in the poll how many it looks like there are in your area.
And Tracy, while folks answer that, just to let you know, I've put in the chat a temporary login if you don't have a login to Pathways, but you want to.
And that's for the clinician login that we're going to be using after. Right now, we're using the public facing piece.
Perfect. Thanks for clarifying.
The piece we just showed, actually, it looks, you can look it up on your phone too, pathwaysmedicalcare.ca. So just how many do you see there? And once you've submitted your answers, if you think there's anything missing, send a message to Michelle Briere at pathwaysbc.ca. All right, so how does it look, Katrina? Don't want to spend too much time on this one. All right, so somebody's got one with no listings. I hope that that's an error. And then anyway, make sure to let Katrina know, or Michelle know if there's any, if it looks like things are missing in your area. The wide public launch hasn't happened yet, so perfect timing to tune that. All right, so now we're going to focus on the clinician login part of Pathways. And remember that Pathways access is for all physicians in BC and their teams. That includes MOAs, RNs, nurse practitioners, midwives, and PCN pharmacists, primary care network pharmacists, role-based access for social workers, mental health workers. Make sure you have your own Pathways account so you can save your own favorites. And if you've been using a clinic-wide login, I would encourage you tonight to switch from a clinic-wide login to give yourself your own access key so you can save your own favorites. And you can do that by going to the contact us at the bottom of any page or by doing the request access from the homepage. So Pathways historically was evaluated in 2015 by GPSC. 97% said it had improved the referral process. Pathways had over 5 million page views from logged in clinicians and our teams in the past 12 months. And most of us have 3 browser tabs open for everyday work. We open our EMR, we open Up to Date as a textbook, and we open Pathways to look up specialists, including those that do telehealth and what the local protocols are for referral. We use it to send patient handouts and to look up clinician resources. And the patient handouts are emailable in bundles from Pathways, and also the latest public health updates in the banner. And in addition to being a listing of specialists, Pathways is a curated gateway to the internet and various clinical tools. And it just makes it so much easier to use internet tools in real time if you get to them through the Pathways search. So for example, the Bugs and Drugs manual, it's much faster to get to any page of the Bugs and Drugs manual by typing in the name of an infection like sinusitis or pneumonia, or today I typed in mastitis to get straight to the right page of the Bugs and Drugs manual. And so that's a tip. Some of you may not know that you can get straight to the right page. So basically, Pathways makes it possible to use internet resources in real time during a patient visit. I'm going to show you a little video about how to email patient information from Pathways. Here we go.
Welcome. In this short video tutorial, we're going to explore the feature of emailing handouts to a patient during an office.
Did I remember to share my sound?
Yes,
Katrina?
you did. We can hear it.
Good.
Office visit or telehealth appointment. To illustrate, let's take an example scenario. So you have a 54-year-old patient who's complaining of pain and stiffness in his right knee. You suspect moderate to severe osteoarthritis of the knee and are considering referring him to an orthopedic specialist. But before doing so, you've decided they could use some educational information about coping with knee arthritis. If you know the name of the handout you wish to share with your patient, you can use the search bar located in the top right. Using this feature will only allow you to email one document at a time. So if you're looking to provide your patient with multiple handouts, you'll want to locate your documents from within the desired specialty. To do this, from the Pathways homepage, click the Select Specialty or Service tab on the top left, and then you can select Orthopedics, and then click on the Patient Info tab. This will display a variety of patient handouts and assessment tools in alphabetical order. If you have handouts that you use regularly, you can favorite them by clicking on the heart icon next to the handout. These favorites can be quickly located for easy access in your Favorites tab in the black menu bar at the top. To select the documents you'd like to send to your patient, click on the envelope icon next to the handout title. Before sending handouts to a patient, you must first get their permission to email the information and assure them that none of their information will be stored on the Pathways system. Once you've selected all the desired handouts, click the Email Selected Items button located at the top of the list and send the information to the patient from a secure, no-reply email address. After you've sent the handouts, a notation will appear at the top of your screen documenting the information you've provided to your patient. Click the Copy to Clipboard button and you can quickly and easily paste the notation into your EMR software. Other commonly used patient handouts are in the specialty of neurology, where often accessed topic areas for handouts include benign positional vertigo, concussion.
Okay, I'm going to stop there. And so that gave you a good overview of how to email patient information from Pathways. And you can see more of those kind of training videos if you go to the U tab in Pathways. And the U tab will show which division you're viewing from as well. And you'll be able to see if you have your own individual account or not. And so you can, on your own time, watch a few more of the training videos. And I'd like you to all log into your own Pathways accounts now to answer the next poll question, which is, when you look at the U tab, is your account for you as an individual or for your clinic or group? If we can just post up that poll. Okay. And how's the answers looking there, Katrina? Again, we don't need to spend too much time on this. Okay. All right. So most have individual, but those of you who have clinic accounts, I would encourage you to request a switch just by going to the Contact Us at the bottom of any page. All right. So there, that's what it looks like, the Contact Us at the bottom of any page, or you can hit the Request Access. So what we're going to talk about today are the care pathways in Pathways. The first care pathways that came to Pathways from a shared care project from gastroenterology were the GI care pathways, including the irritable bowel, dyspepsia, and constipation care pathways. And I'd encourage you all to go to to click and select the specialty of gastroenterology and check out those care pathways. And today we're going to focus on the early pregnancy care pathway. So I'm just going to take a moment and we're going to go into Pathways here. So first I'll just show you, if you go to gastroenterology, you can see that there's the GI care pathways. This is what the irritable bowel one looks like. And notice it's got these nice bundles of emailable bundles of information. So if you wanted to send low FODMAP diet and irritable bowel to a patient and send a bundle of them, you can actually hit the send the full bundle of information, and it'll go to the patient from a no reply email. So let's go to the specialty now of obstetrics and gynecology and take a look at the new early pregnancy care pathway created with support from the GPSC Maternity Working Group. So if you look at this care pathway, there's some quick links up at the top of it, and it bundles things for you into 4 key buckets: dating the pregnancy, reviewing lifestyle factors, blood and urine tests, and genetic screening. And you can click on any one of these to go straight to that section of the pathway. And you'll notice as well, there's a billing one that takes you straight to the information about this particular fee. So notice at the top, we've got the referring the patient to a maternity provider. If you wanted your patient to take a look at that Pathways medical care directory that we just looked at, you can email them the link. If they want to explore the Find a Maternity Care Provider section to decide, you could email them the link to review the medical care directory, or you can look, if you're not sure about who's providing maternity care in your area, it'll take you straight to a pre-filtered page of the clinics taking referrals in your area. I'm seeing the clinics in my geographic area because I'm logged in as a user in the Fraser Northwest area. Going further down, it reminds us to do the dating ultrasound between 8 and 13 weeks. plus minus nuchal translucency. And as somebody who doesn't do a lot of obstetrics, I go, well, what's nuchal translucency again? And it reminds me it's an ultrasound to measure the thickness of the fluid buildup under the skin at the back of the developing baby's neck. And I have to say, I learned that in the course of preparing for this session because I've never completely understood, I'm sorry to say, exactly what the nuchal translucency was. And notice it also gives you the list of available sites for nuchal translucency for the patients who would qualify for that. Going down to lifestyle factors, we've got quick reference about how much folic acid to supplement. And if the patient has questions, you can take a look at what that link shows. It shows the SOGC information. And if you think the patient would like it, you can email that to the patient straight out of the algorithm. I think we want to send all of our patients information about nutrition and physical activity in pregnancy, and also the Baby's Best Chance Handbook. This is the link to the Health Link information about nutrition, healthy eating during pregnancy. So if you wanted to send a bundle of both nutrition and physical activity and Baby's Best Chance, you hit that, and then we can send it to the patient, and it'll go from a no reply email. I could add an optional message like, here's the information you requested. I hit email to recipient, and now I'm going to copy to clipboard. And if I had my EMR open, I could paste it into the EMR that the patient gave their consent and what I sent them. And if I send information to patients from Pathways and paste it into my chart like this, I always keep it at the bottom of my note. And I say to the patient, I'm going to be asking you about these handouts, and I'll be interested to know which of them you thought was the most useful or what you took from them, so that they know that actually we're going to be coming back to, I'm going to be asking them about it. There's other things, and I want to say we should all take a deep breath and not get completely overwhelmed about this either. Like, you don't have to do every one of these things here. It's just here to make it quick to do a subset of these things, and to make it quick to find information you might be looking for, and to be able to do all of this in real time during a visit. You can poke around yourselves later and explore more of these, just opening them up. If you've never looked at the mother to baby fact sheets, they're fantastic. I'll open it and point out that when you look at the mother to baby site, you do need to scroll down to the fact sheets, but there's, cosmetic treatments, drugs, foods and beverages, health conditions. So they've got fact sheets about all kinds of things. And if the patient is on a medication, and they're worried if it might have an effect in pregnancy, these are great. And then there's the 10 great reasons to breastfeed. Moving into the blood and urine tests, the basic recommendations about the blood and urine tests. And if you don't have the standard one in your EMR for all the prenatal stuff, this lab rec is the one that has all of the prenatal stuff on it. Then moving down into the genetic screening, just a reminder that we're supposed to offer appropriate tests to all patients based on their age and when they access care. The most common thing is the SIPs, and a reminder that these are the things that the SIPs tests for. And then if you want to send some information to the patient, there's basic FAQs from Perinatal BC, and we can open that up and take a look at what's in the basic FAQs. And if you want to email that one to the patient, you can. If you need multilingual, this is links to multilingual information that you can email to the patient. This is a nice visual screening aid. Takes a little bit to open up, but it's a visual screening aid of what of the potential for a positive and negative, and what a false positive and false negative might mean. So a small percentage of women will screen positive and have a baby with Downs. A small percentage will screen positive, but the majority will have a normal, healthy baby and be false positive. So that's just a visual to review that. And then if the patient is interested in private pay NIPT testing, Then there's information from perinatal services that explains the difference between private and publicly funded options for them to explore, and a map or a list of the locations. So again, you could send them a bundle of the FAQs and the locations. And if you scroll down to the private pay table, here's the 2 private pay NIPT requisitions. And something else I learned during the course of preparing for this about nuchal translucency, in addition to finally understanding exactly what it was and what it was testing, if a woman is over 35, she's eligible to have a publicly funded nuchal translucency. And to order one, all you have to do is write nuchal translucency on any ultrasound requisition and add the due date. And if you click here, you'll see in Pathways the sites in your area that offer, that's pre-filtered for publicly funded nuchal translucency ultrasound. So I can see in my area, these are the places that I could send a patient for a publicly funded nuchal translucency. And I think actually, boy, I went through that quickly. Let's see what else we had on the slides about that. Take a deep breath was a big thing. Not, you don't have to do everything in one visit, nor is it a requirement for the fee. It's just intended to try to make things a little simpler. Remember to book the dating ultrasound for 8 to 13 weeks. Remember to do the lifestyle review, and maybe definitely make a point of sending Baby's Best Chance and the nutrition one, but you could certainly send any of these others like registration for Best Beginnings, and that maybe it makes sense to do some of these on a second visit. I'd like all of you now to try emailing that bundle of Baby's Best Chance and nutrition and physical activity. Try emailing it to yourselves from Pathways, just to get a feel of what that is like. And notice it's this one with the black lines beside it. That's the combined bundle of the 2. So can you put up the poll, Katrina, and have people let us know how it went when they tried to email those 2 to themselves from the algorithm. So to get to the algorithm, you're going to be logged into Pathways, and you're going to go to the specialty of obstetrics and gynecology here. And when you click on that, you'll land here and click into the early pregnancy care pathway. And then you'll be there and try to send those 2 general information about pregnancy to yourself.
Tracy, there was a question about what does it mean when it says my account is not active?
It means
do I need to use the account to keep it active?
You don't have to use it much, but they get deactivated after 5 years. So I guess you haven't used it for 5 years, but just hit request access at the bottom of the login screen, and request to have your account reactivated.
There's also the comment about Invitae not being listed as part of the non-invasive prenatal screening self-pay. It is only $100, and that is not included on your list.
Yeah, we had a discussion with the genetics people from Perinatal Services, and they had some concerns about some of the stuff with Invitae. So they asked that I not include it at the moment until there was, and the concerns were about some of the micro deletions and other things that they were offering. So I were waiting to add them. It wasn't about their NIPT. It was about all of the add-on services that end up kind of getting bundled in there. So yeah, just waiting to hear back about inclusion of Invitae.
And there's one that is more just a comment, quite frankly, because I know you don't have the answer. With all these great resources, referral networks, etc., why is Pathways not integrated into our EMR?
And Pathways has an API and can be integrated into the EMR. And it would be wonderful if all of you write to DTO and say you would like to see pressure to have pathways integrated into the EMR, because it can be, and the API is built, and it just hasn't been made a priority. But there's so many ways that it could be, it's already useful in a separate tab, but it could be right inside the EMR, and even the listings of specialists could be in the EMR. And in some parts of the province, referrals can actually be sent through Pathways, through the Pathways referral tracker, which would be even better if it was fully integrated with the EMR. So on Pathways side, Pathways is ready and just waiting for there to be some pressure from the ground to request that extra layer of functionality and enhancement that would come. But it needs to be both, it needs to be prioritized. And as users, ask your EMR vendors and ask DTO to make it a priority, but ask your vendors, say, hey, we'd like our EMR to integrate with Pathways.
And there was one comment that the Invitae is no longer bundled with the other pieces. It's a separate cost now.
Mm-hmm.
And just a quick question about a reminder about how to send multiple email info from the pregnancy algorithm to patients.
Okay, so how to send a multiple email. So you'll notice the times where an envelope has two black lines beside it, it's a bundle. So this one's a bundle, and it says send bundle email of both items below. So I hit that, and now it's going to have attached both of those, and I can send it anyway. We don't have to do it right this minute. But so out of the algorithm, that's how you do it. And then if you wanted to send multiple emails not inside the algorithm, let's say you wanted to send multiple emails that were somewhere else here, like you wanted some breastfeeding information and you wanted to send 10 great reasons to breastfeed and breastfeeding basics, you need to access the handouts within the specialty. So if you try to get to the handouts from here, so I type in breastfeeding, and now I get an overwhelming bunch of results, and I think, oh, but I actually wanted patient information. So that narrows it down for me. But if I pick one, like if I pick the 10 great reasons, then I'm going to be able to email that one, but I'm not going to be able to email a bunch of things. I'll just be able to email that one. But if I want to email a bunch of different handouts, then I have to go into the specialty. So here I'm in the specialty of obstetrics and gynecology. That's where we are. And I'm going to be landed in specialists, but I need to go to the patient information collection in the specialty of obstetrics and gynecology. And I've filtered it for breastfeeding and lactation advice. So now I have the option to send multiple handouts about breastfeeding from within the specialty collection. So yeah, I think I answered that.
Yep. So there's one other question about when you've sent patients the information, do you have to open up Pathways inside the EMR to clipboard to the patient charts?
No, you just copy to clipboard. So you saw I was here, let me go back and do one out of here, I'll hit this one. And I go to email it to the patient, email to recipient. So now when I hit copy to clipboard, it's on my clipboard in the browser. So if I go to my EMR now, actually, no, go to my EMR here, go to this. And so I just hit paste, or you could do it like if you wanted to do however you normally do paste, you can do it like that. But you just paste it into the EMR. So you don't have to be inside the EMR you can put anything from a clipboard onto the EMR. Okay. Blood and urine, we talked about genetic screening. And I would encourage you to take a moment after the webinar, or maybe have a moment now to just look at the genetic screening FAQs, look at the multilingual information, the visual aid that I showed you, the private public options. It'll only take you 5 minutes to look at each of those and feel comfortable tomorrow and for the rest of your life sending, like, referencing them. I often look at this stuff while I'm talking to the patients. If they're in the room with me, I show them and we read the stuff together, and then I hit the email icon and they can read more of it at home. But having us read it together, and if I'm on the phone with them, I email them stuff while we're talking, and I have them open it up while we're talking and we read through it together. I don't think we need to do another email. I'd encourage you as well to click in and look at things like, which are the publicly funded sites offering nuchal translucency in your area. If you have patients over 35 and are eligible for that, and take a look at the private pay options for NIPT, and they can be done from 9 weeks on, and take a look at the requisitions. And once we have clearance from the genetics folks at Perinatal BC, the Invitae will be added as well as another option added into the algorithm. And then here's the definitions at the bottom of the algorithm of all of the different tests. And within the algorithm, if you click on any of the words, so if I click on nuchal translucency, I showed you, it takes me to nuchal translucency. And if I click on IPS, it takes me to IPS. So these are all anchored to their definitions lower down in the algorithm. It's a little CME moment, as well as a way to streamline your ability to get this stuff done quickly and confidently. I know I actually did one last week and felt like, oh my God, I'm not a bumbling idiot. I actually have a grip for the first time in 30 years. So anyway, I hope it works as well for you guys.
So Tracy, is there someone they can connect with if they're having difficulties with the clipboard function not working for them?
I mean, that's something relating to your computer setup. So whoever does your tech stuff for your office, because clipboard is a basic browser function. So maybe talk to whoever is your tech person at your office, because that's a basic function of a browser. It should work. Okay, I think we're back to you, right, Kath?
Yep, I believe we are. Let me share the screen from mine again then. Share screen. There we go. So now we're going to do a quick review of the MSP fee codes for pre and postnatal care. Tracy, did you, let me go up one. There we go. So for those of you, because you're on this is the slide you showed, right?
Right.
Right. So we're going to go into some of the actual codes and talk a little bit about how to use them if you're doing virtual care. Just as a note for everyone, the fee codes for the prenatal CPX visits and postpartum visits are going up. The increase for the prenatal CPX itself is up by $1.99 from previous. The differential that you're seeing here of just over $17 is the differential with the base 0101 complete physical.
And I'll just say for the folks, I'm somebody who never used any of those codes, 14090, 91, or 94. I just always used the 0101 or 0100 series, and they used to be worth exactly the same. So I never thought there was any reason to bother learning the 90, 91, and 94. But there's now a big difference between the two. So it probably is worth it. For the extra $17 to learn that if it's a prenatal complete, to use the 90, and if it's a prenatal basic visit, it's an extra $5.50. Might as well use the 91.
The other important thing to know is that none of the prenatal visits count towards the HV lip limit.
The high volume limit.
They are excluded from those calculations, if you're ever wondering about that. Effective April 1st of this year, these codes are restricted to family physicians. The obstetricians now have their own codes because they didn't want us to put the value up, and we wanted to put the value up, so they have their own codes now.
So there's some questions here. 14002.
Tracy, I
Yep.
really would like to hold off on the questions
Okay.
because it's already 2 minutes to 7. Let me
Okay.
get through this first,
Sure,
and then
yep.
we'll deal with the other questions because I have
Okay.
seen them as we've been going through. So again, a quick review of the MSP fee codes. The 14090 is the family physician, family practice prenatal complete physical. The 14091 is the family practice prenatal visit, subsequent visits. The 14094 is the postnatal visit. We still will often bill the counseling if the visit meets the counseling codes instead of a prenatal visit. For example, you get someone in at 16 weeks for who's booked for their prenatal visit, but you've just gotten their SIPS testing back and their risk is high, and you need to actually do some counseling that meets the preamble requirements to help them understand what it means, calm them down, and get them set forward. So we will use those instead. An office visit, if you are providing care that is unrelated to the pregnancy, you will still bill a regular office visit or the age differential telehealth fees if appropriate. So the CPX, I'm not going to go into it in detail. Again, it is about that complete physical, including a PAP if indicated. If not indicated, then you don't need to be doing it. Go by BC Cancer's PAP test recommendations, because if they're not within that 3-year window, you don't need to do it just because they're pregnant. As we move towards HPV self-testing, we do not want them to do HPV self-testing during pregnancy because BC Cancer is concerned about how far they might stick the swab up the vagina. So we're not there yet from across the province. It's right now just in 3 communities on a pilot basis, but hopefully we'll hear sometime sooner rather than later that it will be expanded across the province. As I said, the 14090 does not count towards the HV lip calculation. If you are a provider who takes on referral patients, you can bill that. As I said earlier, you can bill the 14090 in that patient when you take them on, even if their own family doctor had billed it earlier in the pregnancy. But you do need to include an electronic note to MSP that indicates it is a transfer CPX. MSP does not consider temporary substitution of one physician for another, or being days off, vacation time, are not considered a patient transfer. It is an actual full transfer of the care ongoing. Prenatal visits subsequent to the 14090, prenatal visits are 14091. Uncomplicated prenatal care, of course, we usually do it once a month till the 3rd trimester. Then we increase frequency every 2 weeks till around 36 weeks. And for the last month, roughly once a week. There are 14 prenatal visits, excluding the 14090, excluding the CPX one, that are billable per pregnancy. Now that is any combination of the family practice prenatal visits or the specialist prenatal visit, which is 04091, I believe. So MSP, that's limited to the 14. So if you're in a shared care situation with a higher risk, a more complicated patient, not to worry if you do end up where any of your prenatal visits get rejected because they've reached the maximum. Simply resubmit them with an electronic note that states shared care with obstetrician, patient requiring additional care due to hypertension of pregnancy, something along that line, something that explains to them. E-notes are your friend. They are your opportunity to tell the MSP computer that there's something special about this visit that I'm billing for, and kick it out to a real person instead of the computer. Whoops. Counseling visits, I already talked a little bit about that. If you're providing counseling that meets the criteria, you can bill the counseling visit instead of the prenatal visit. Even if you've done the listening to the fetal heart and done the prenatal component, you do not get to bill them both, because then the prenatal care is included as part of that. Unrelated visits, the in-person and virtual. So if you're providing something that is unrelated to the pregnancy, sinus infection, something along that lines, you bill the regular office visit age differential. If you are providing, I'm going to go quickly back up to the prenatal visit and the postpartum visit for both of these. If you are providing prenatal care virtually, or you're providing postpartum care virtually. Say you're touching base about their mood, they're developing some mood problems during pregnancy, or maybe you've had to start them on an antidepressant at some point because their depression is getting that severe, and you want to follow up with them about side effects, but you don't want them to have to come back in. You can still bill that under the 14091, but you need to put an electronic note that states prenatal visit by telehealth, or similarly, if you're doing postpartum visits virtually, you would put a note, an electronic note, postpartum visit by telehealth. You will then get paid at the higher prenatal and postpartum rates rather than the telehealth fees. Talked about the counseling and that. So a reminder, and I think it was Tracy who found the Boeing 707 airplane. 707 is that ongoing temporary code. We don't yet know how long that will be there for, but for the relay of advice through your MOA or nursing staff, or if you have had to submit prescription refills, instead of the 14078 currently, which does have a maximum of 200 per doctor, the 13707 has no maximum per physician. And it also has the prescription refill, whereas the 14078 does not have that included. So while it was created for the pandemic, it is still in effect. And so if what you're doing is refilling a prescription, then bill this code for that service. So workflow considerations: an in-person visit to confirm pregnancy, and limited examination as clinically indicated, that's separate from the maternity care risk assessment. So that's, as I said, if you've got a patient who's come in, they're let's say they're 8-9 weeks pregnant, they've had a positive test at home, they're really nauseated, you've done the initial genetic screening review, the all of the other components of that maternity care risk assessment, and then you're talking to them about their nausea, you're talking about eating small amounts frequently, offering them potentially medication. That is a visit that is separate from the maternity care risk assessment, so you are able to bill both the visit and the maternity care risk assessment. If they're only around 6-8 weeks pregnant, I would not be billing that using a prenatal visit code, because you haven't gotten them to where you've done the complete physical. You would still use the visit, whether it's a telehealth visit or an in-person visit. You use the appropriate visit code. You don't need to indicate to MSP that they're done separately, but you do need to include that in the documentation in your chart. So now we're going to go on to poll 6. So Ms. Joyful is a 23-year-old patient who had a positive pregnancy test at home last week. Her last menstrual period was about 2 months ago, but she does have slightly irregular periods. She's been very nauseated, and while not vomiting, she finds she's not really able to eat a broad variety of foods. You examine her for dehydration and provide some symptom management advice, and you then, so in this case, I put the medical visit first, then you undertake a maternity care risk assessment, arrange the dating ultrasound, and give her a SIPS-1 requisition. What fee codes would you bill? Can you pull up that poll? Thank you. So you can bill multiple choices here. We'll let you give you a little bit to fill in which are the codes that you would bill for that that visit that's at around 8 to 9 weeks gestation. I feel like I should have the Jeopardy. Dun, 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 dun. Dun, dun, dun. I'm a Jeopardy fan. We'll give people a chance to answer. And so yes, so okay. So yes, you would bill the in-office person visit. You would not bill a complete physical because you haven't done a complete physical. You would definitely also bill the 14002 maternity risk assessment. While you theoretically could bill the 14091 prenatal visit, that's usually not billed until after you've done the first prenatal complete physical. Again, the 14090 in my description of this You've talked about the nausea, confirmed about the prenatal risk the maternity care risk assessment, but you haven't done a full physical. So you would not bill the 14090 because you have not done that. And then let me go through here. So these were the answers that were allowed, and the correct one 00100 and the 14002. If you did that visit by virtual, right? So if you are only doing the risk assessment and you're not providing any separate medically necessary visit information like the management of the nausea, then you would only bill the 14002. But by and large, your patient usually has other questions to ask that aren't about the risk assessment, going through all those questions, that are about things that have come up during the pregnancy. So poll 7, so what if Ms. Joyful wasn't able to come to your office? So you've been through everything again, you've given her some information, you've offered her possibly referral to your nausea and vomiting clinic, but she actually doesn't feel she needs it because she is not getting dehydrated and is able to manage some food. So you give her the symptom management advice. She agrees to try the diclectin, and you undertake that risk assessment. Provide her again with the dating ultrasound and the SIPS1 requisition. So what code would you bill here if it's done virtually? Poll 7. Katrina is my Vanna White. There we go. Ta-da! Which of these would you, again, it's a multiple choice, which of the codes would you bill for this virtual visit now? And I will let Katrina let me know when she's going to bring up the answers.
Yeah, if you want to go to the next slide, I'll then end the poll.
Perfect. Thank you. All right. And there we go. So there we go. Yes, the telehealth visit age 2 to 49 plus the maternity care risk assessment. Correct. Again, you could bill the 14091. It is a little early in the pregnancy. If you do bill that, you make sure you put the electronic note that the prenatal visit was provided virtually. You wouldn't use the visit in person, the 0100, because the patient's not in front of you in the office. It is a virtual visit. You could definitely bill the 13707. Tracy, am I right? You can bill that as well if you're faxing it in, or is that only if you haven't had a connection with the patient at all? Tracy?
You can bill the 13707 just for faxing in a prescription refill.
Okay. In addition to the visit?
No, it's
Okay.
you can't bill it at the same time as a visit.
So
on the
if
same
you
day as a
faxed
visit.
in, if you faxed in or called in that prescription at that point in time, you would not be able to bill the 13707.
It's not billable on the same day as a visit.
There we go. All righty. So here we go again with the next workflow consideration. You're undertaking the maternity risk assessment at the initial visit, and you're having the patient return after they've had their dating ultrasound, or if they're a little older, both their dating ultrasound and nuchal translucency. I have to say there are some of the radiology clinics will do the nuchal translucency measurement at the same time as the dating ultrasound. Others will do the dating ultrasound first and then rebook them for the NT part. So find out what your local ultrasound offices will do. So again, when you bring them back for the full physical, after they've had that, you can do the CPX at that point in time and fill in any missing information that you want to add in that you found out in the meantime. So for the complete physical, you bill the 14090 only. In this situation, because you had done the maternity care risk assessment at the earlier visit, that you would have billed with a visit fee if you provided that additional service in office or virtual. So we have one more poll here. What would you bill if all components, the complete physical and the maternity care risk assessment, were done at one visit? Poll, please, Katrina. Thank you. Multiple choice here, gang. You're doing the prenatal complete physical and the maternity care risk assessment. What would you bill? go to the next answer slide so we can see on the recording. And Katrina can give us the answers. And most everybody has gotten this correct. You would bill the 14002 maternity care risk assessment fee, and you would bill the 14090 family practice prenatal complete examination. The 14091, if you've done the complete physical examination, you would bill the 14090. You wouldn't want to bill the 00101. You could, but it would be appropriate if you were doing that first prenatal complete examination to bill the 14090. As we said earlier, that value is now $17 higher than what the 00101 is. And poll 9. So I'm giving you all of the workflow polls all back to back. Sorry here, gang. So Ms. Joyful calls your office and tells your MOA that her nausea is still causing her a bit more difficulties, and she's running out of the diclectin. She's only been taking it at bedtime, so you ask your MOA to relay back that she should add 1 diclectin in the morning, and if needed, she could take another one at noon, and that you will fax a refill prescription with the new instructions to the local pharmacy. What code would you bill for this? There's our multiple choice. Again, this is for this specific service. Which code would you like to bill at that point in time? You haven't had a direct visit with her yourself. You've had your MOA relay the information, and you fax the prescription refill in. I think I've probably given you the answer there. Let me get to the next slide so that everyone who's tuning in at a later time can see the different codes. And correct, 96% of you got the right number, 13707. That is the family practice email, text, telephone, medical advice relay or prescription refill fee code. You would not bill the telehealth visit because you yourself are the one who has to provide that service. Direct visits, telehealth or virtual, are not, you cannot delegate them to your staff. You have to be the one who is connecting directly with your patient. And then very quickly around the transfer of care, and we know that about 1/3 of the people who registered for the webinar tonight do deliveries, so you're likely accepting referrals from your family physician colleagues who do not do deliveries. So as said earlier, the 14002 is payable once per pregnancy per patient, except in the case where the ongoing prenatal care is transferred to another family physician for the balance of the prenatal care and delivery. So the OBs can't bill this. They're not eligible. It is only for family physicians who are accepting these referrals. The second physician can also bill for this service with that electronic note that states that it is a transfer situation. So similarly, the first prenatal complete physical, the 14090, can also be billed a second time by that accepting physician, the one who's accepted the referral. Both times, because they are a second billing within the patient that pregnancy, you need to have an electronic note. So as I said, what I do in Oscar, I click on both the 14090 and the 14002, and I do the one electronic note that states transfer of care at 18 weeks, 20 weeks, whatever it might be, transfer CPX and maternity care risk assessment provided, period. That goes in, it's connected to both of those billings, and that's what MSP's computer needs to see to know that the second billing is appropriate to be paid. So this poll is for those of you who are doing referral obstetrics. If the rest of you would like to answer, you can, but it is specifically for this group. So Ms. Joyful, the same patient that we've just seen, the family doctors managed her for the first part of her pregnancy, first trimester, and referred them on to your office. You've seen her at 17 weeks. She's undertaken the initial risk assessment and already sent her for ultrasound and SIPS-1. You've got a copy of the information from the family doctor office. She did indicate that Ms. Joyful has the SIPS-2 requisition, so you don't have to give it to her again, and you are copied on the result. So you review everything and you undertake a transfer CPX without the pap test because that was already done by the family doctor or may not even have been due at this time. So what fee codes would you bill for this service? Thank you. Katrina has popped the poll up. We'll give everyone a few seconds to give us their answers.
After this, we'll run through some questions.
Yep, we'll get into the questions very shortly. Alrighty, and I'm going to go to my next slide, which has all of the answers listed as well. And the answers correctly are the 14002, the maternity risk assessment, and the 14090, the first prenatal complete physical examination, both of which you will include that electronic note. You've done the full physical, so you do not need to only bill the prenatal visit. You've done that service because that's the appropriate thing to bill. All righty. So we get now to this. Trace, did you want to quickly do that, or do you want me to
Maybe I
answer
think we
questions?
should do the questions first.
Sure. And
So
that's fine.
14002, can it be billed at any time in the pregnancy?
So yes,
Yeah.
the 14002, it's not restricted to any specific point. Obviously, the majority of times it'll be billed in that first and early second trimester, because that's when a lot of that prenatal genetic screening is. But patients may not be transferred until later in their pregnancy, or they may not even show up in your office for their initial care until later in the pregnancy. So absolutely, it can be billed at any point in time when you provide the service at any point during the pregnancy.
Then can it be back billed? Yes, it can be back billed to the date it was effective, which was April 1st. So if you did provide care April 1st or after that involved this, you could backdate the bill to the date you did the care, as long as your note documents the things that are consistent with the fee.
Remembering that it must have the date of service that you provided that service. So if you today realized you did one on April 4th, don't bill it with today's date of service. You need to bill it with April 4th date of service. You can bill up to 90 days retroactively.
So, but you can't bill for them done earlier than April 1st because
No.
this fee became active April 1st. Is this going to be retroactive at all? Retroactive to April 1st, nothing past that. And is it reciprocal to other provinces? I don't think
No,
so.
it is not.
Okay. And do I have to bill 14090 before starting to bill 14091?
You don't have to. You bill 14090 when you do the full physical. You know, if you've done a quick, say someone has been transferred to your care and they've had a little bit of spotting or bleeding, so they're a bit anxious, and they come in, you listen to the fetal heart, it's good, it's strong, and their CPX is booked for a week or two later, that's fine. You can bill that as a 14091 and then bill the 14090 when you do the complete physical the following week or two, whenever it's scheduled.
If we accept referral obstetrics, should it be assumed to write transfer of care with all 14002s? Do we think this is a code most people would have used early on at the time of pregnancy? I think yes. If you're taking the transfer, you should probably assume it's been billed.
It won't hurt if you put it in. The only time that you may not want to is if someone's literally been referred to you and you've seen them at 8 weeks and you know that nothing else has been discussed or done because that's what they've told your staff. So, but otherwise, absolutely, for those who are doing referral maternity care, you might as well assume that it's happened and just have that standard little e-note, copy and paste it into the fee codes when you're billing it.
Does prenatal complete physical require a PAP?
Not necessarily if it's not due. If it's not due or it's not indicated for other reason. So as an example, if their PAP isn't due until next year, you don't need to do a PAP just because they're pregnant. If they've had bleeding and there's any concern about a placenta previa, then I would not be doing a PAP test because I don't want to cause any problem there. So clinical judgment, whether or not, if it's due, whether or not you do it at that stage or whether you defer the PAP test to the postpartum discharge exam, that 6-week discharge exam, that's a clinical conversation. So it's not an absolute requirement. It really is about the clinical indication.
We have a ton of questions, so we're going to do short snappers. Can you bill multiple postnatal visit fees until 6 weeks postpartum?
The answer to that is yes, we had that de-linked from the delivery code many, many years ago.
Okay.
But we're not specifically talking about that here.
Will 14091 be rejected if 90 hasn't been billed yet?
No, it will not.
No. Is there a limit to how many 14094 visits you bill for a single patient?
We already said no.
Is 1004 going to be billable again for our patients receiving the pertussis vaccine in pregnancy? I don't know.
I'm afraid right now I can't. I believe it is in the fall, but that's something I would stay tuned. It's not part of today's webinar.
If I accept my current patient's newborn care, can I bill 14041?
So Tracy's going to talk about
I'm going to talk about 14041. And the answer is yes, the baby's a new patient, and we're going to talk about that. And if we get referred OB patients at various stages, is there a way to tell if the referring provider has already billed it? I would say just put your fee note in.
Just assume it is happened, because there is no way other than until you get rejected. No point in doing that. Assume it, put the note in, and then you don't need to worry.
And sorry if this was missed, can you bill 14091 in addition to 0100 if there was a non-pregnancy related concern on the same day?
The answer is no.
No, they're the same kind
All
of a
other
visit.
care is covered under the, just because you've listened to done the prenatal care and checked their throat because they've got a sore throat, it is all covered under the prenatal visit.
And so to close here, we will,
sharing.
and I will share my screen. And are we on the CLFP new patient intake? You can see? Yep.
Yep.
So taking the new patient, a baby is a new patient. So when my patients have a baby, when I take on the baby, that baby is a new patient. And so I can bill the 14041. Obviously, I'm not having the conversation with the baby. I'm having the conversation with the mom that I've taken on the baby. And if you're taking on a new mom and baby, you can bill the new patient intake fee for both of them. And just to reiterate, the new patient intake is basically just for the, the administrative process of taking the patient onto your panel. It has to be billed within the first 3 months of taking on the new patient. And you have to have had a visit within the 3 months prior to billing it. It can be the day of, and usually with the baby, I bill it the day of. Payable to the MRP. So these are only payable to community longitudinal family physicians, to CLFPs who've met the requirements for 14070. It's not payable to a locum, only payable to the person who's willing to say to the mother, I am your baby's doctor. I'm your doctor. I'm your baby's doctor. It was effective back October 1st. You need to review the compact with the mom, which is the compact is this document that basically you're saying, I'm your family doctor and your baby is my patient. And this compact has been part of the CLFP portal since 2014. This is the updated version of it. You should all have it on your wall in your offices for the patients to read. And it can also be emailed to a patient from Pathways. Just type the word compact into the Pathways search and you can hit the email button to email the compact to the patient. If you've been a locum in a practice and start to take on and become a longitudinal doctor in that practice, so you've seen the patient before, but you were a locum last time, and now you've committed to taking on a panel of patients, then you're going to need to submit a note record explaining that you've taken on the patient now for longitudinal care. And if you're taking over the practice of associate who retires or is sick, and you've seen the patient before when you were in the shoes of, covering for your partner, but now you're taking on the patient again, you're going to need to submit a note record. So I think that covers it. 7:28, 2 minutes to spare. Oh, we got some questions. When will can you bill a 14066 during pregnancy, not at the same time as a 14002? You can't bill it on the same day. And Kath, did you want to
Yeah,
comment
and you know,
further?
and you need to really be, you need to consider what's the need for doing the 14066 personal health risk assessment service when all of the information that's a part of that will also have been done when you did the 14002, because that's included as part of it. So I think you just be cautious, you know, if something has changed later on, because there's more to it than just talking about smoking cessation. And I really worry that too many people think of it as a fee for smoking cessation only, and that's not what it's actually designed for. So be cautious, think closely about why you're going to bill it before you would bill it.
Yeah, read the fee requirements and make sure that you've met the requirements for the fee. Just to clarify, 14041 should not be billed by a physician temporarily taking a patient for prenatal care. No. The 14041 is specifically for taking on a new patient into your ongoing longitudinal panel. And it should not be billed for taking on a patient for 9 months for pregnancy. It's specifically for committing to longitudinal care, hopefully for many years. So no, not for prenatal care. I forgot to bill 14041 for a new baby 6 months old. You can bill it, yeah.
Except Tracy, you said that it had to have been within the first 3 months. So if
but
you're
you
going
could
to bill
backdate it now 3 months,
Yeah.
and it would be within the 3 months of having done it. So
backdate it to the date to when they were 3 months of age, when you saw them in that time frame.
and it doesn't have to be from a day of a visit. So that was we answered that one. The locum to MRP situation, do you submit 14041 backdated to your first visit with the patient as a locum or first visit as MRP? First visit is MRP because it's the acknowledgement, and now I am your doctor and you can identify me as your doctor and all of the things that it says in the compact. If you go to Emerge, I'm your doctor. We have an ongoing relationship, which you didn't have when you were there locum. So it's all about the moment of the acceptance of and commitment to the relationship. What is the ICD-9 code for 14041? It doesn't matter. You can use anything. And can 14041 be billed with courtesy obstetrics? No, it's just for the commitment to longitudinal care of a patient. Can it be billed with a visit? The 14041? Yes, it can be billed with a visit, and it can also be billed not with the visit. As long as you document that you've taken the patient on and that you've had the compact conversation with them, whether you bill it the day that you have that conversation or with a date differently, but your chart notes should include that you've had the compact conversation with the patient. For billing 14041 for baby, do you have to document discussion about the compact? I mean, it does seem a bit goofy because of course you're not having it with the baby, but you should say, especially if you're taking on the mom at the same time that you've had the conversation with the mom. And so done. Can CME credits be claimed for tonight? You can claim the unaccredited credits. You know, there's 2 categories of credits. This one hasn't, gone through the process to get the main pro, but there's the non-main pro credits, and half of our credits can be non-certified activities. So this is an uncertified activity for which you can get 1.5 hours of credit. I saw a baby yesterday, they're accepted onto panel. So can I bill 14041 today? Sure. Today or yesterday. I think it doesn't matter because it's not a visit linked fee. You can bill it today or yesterday, but just make sure that there's some documentation in your chart that, you spoke with. If the mom was already your patient, fine. And if the mom was not already your patient, her chart should have some documentation. But does that sound okay?
I think that wraps us up for